Good morning, everybody. My name is Michelle Brunson. I'd like to welcome you and thank you for joining us today for our fourth webinar as part of the 2018 QPP webinar series, a closer look at the Promoting Interoperability and Improvement Activities Performance categories. Presenting with me today is my colleague and friend, Sandy Swallow. Many of you may not recognize the term Promoting Interoperability. CMS recently renamed the former Advancing Care Information, or ACI, to Promoting Interoperability, or PI. This change will move the program beyond the existing requirements to a new phase of EHR measurement with an increased focus on interoperability and improving patient access to health information. Some of the graphics in our presentation will still show the former ACI term, as CMS has not had a chance to update them yet. Also, the resources links will show advancing care information, but look for all of these to be updated soon. Before we get started, let's go over a few housekeeping details. All of your lines have been muted to avoid unnecessary background noise. However, we plan to leave ample time at the end to open up our lines for your questions. You may download the slides on our website at TelligenQPP.com under Resources, and those may be available even yet this morning. The call is being recorded and will be posted to our website as well in the next few days, again, under TelligenQPP.com. Lastly, following our discussion today, a survey will pop up asking you to complete this. Please take 5 minutes or so to do this. We really value that information and feedback you share with us. It helps us plan and prepare our future webinars and technical assistance needed. So who are we? Many of you are familiar with us, but for those of you who do not know us, Sandy and I both work for Telligen in the West Des Moines, Iowa headquarters office. We work closely on 2 separate support contracts funded by CMS to provide no-cost technical assistance, resources, and support for eligible clinicians and their organizations participating in the Quality Payment Program. Sandy and her team serve on the QIO contract supporting all Colorado, Iowa, and Illinois eligible clinicians, especially those in larger practices, health systems, and ACOs. My team and I serve on the small, underserved, and rural support contracts, working with practices with 15 or fewer clinicians in Iowa, Nebraska, North Dakota, and South Dakota. If you are joining us from another state today, welcome. We are so glad to have you as well. If you have any questions about how to reach your CERS or QIOs from your state, we would be happy to connect you. I'll start with some general information about the Improvement Activities Performance category, followed by choosing activities, looking at new activities for this year that were not available last year, as well as changes to existing activities we wanted to draw your attention to for this year too. Then Sandy will provide some general information about the Promoting Interoperability Performance category, followed by more specifics on reporting, scoring, reweighting the PI score to the quality category score, how to score bonus points, and finally some tips to share with you to help you improve your score. We will also provide links to the updated Year 2 CMS Resources to help you. Most of you probably know the Quality Payment Program has 4 different performance categories. You will receive points for each category to come up with a final score with a maximum of 100 points total. This score will be measured against your peers to give you a payment adjustment in 2020 for the 2018 performance year. You will see the weight of each category under the category name. The Improvement Activities category is weighted at 15% of your final score, and the Promoting Interoperability is weighted at 25% of your final score. If you are in a mixed APM, your improvement activity is weighted at 20%, and the Promoting Interoperability is weighted at 30%. So we decided to start with the Improvement Activities Performance category for a few reasons. For those of you who do not have an electronic health record, you do not need one to participate in the Improvement Activities category like you would for the Promoting Interoperability category in the second half of our presentation. You can still score the full 15 points for the improvement activity, or 20 if you're in a missed APM. And if you don't have the full hour, you can drop off after this first part. And keep in mind, we will have a Q&A section at the end. If you do have an electronic health record and you choose an improvement activity that is certified EHRT eligible, you are able to get extra bonus points in the PI category. So you may want to start by reviewing those that are eligible for the PERT bonus and help you get some extra bonus points. And also, there are a lot more changes or updates implemented in the improvement activities category for Year 2 than the PI category for Year 2. So what are the improvement activities for MIPS? This category was new in 2017 for Year 1. The whole premise behind the improvement activities is that practices will work on care coordination that's ongoing, shared decision-making between the clinician and the patient, regularly using patient safety practices, and expanding access as some of those key activities that improve the clinical practice. There are more than 110 activities in 2018, up from 93 last year. The activities are either weighted medium or high-weighted. Medium-weighted activities are worth 10 points. High-weighted are worth 20 points. To get full credit for the improvement activities category, an eligible clinician needs 40 points. The required performance period for the improvement activities category is a continuous 90-day period for 2018, but you can go up to a full calendar year. So anywhere from January 1st of 18 to 12/31 of 18, but at least a minimum of 90 days. Now, those who are a certified patient-centered medical home or ACO will receive full credit. Starting in 2018, 50% of practice sites within the multi-practice 10 need to be certified or recognized as a patient-centered medical home to earn full credit for the improvement activities in 2018. MIPS-eligible clinicians or groups are required to attest to being certified or recognized as a patient-centered medical home to earn this credit. If you are participating in the advanced APM, you will receive half of those total points. And there are some fewer reporting requirements for MIPS-eligible clinicians. One of the biggest is if those practices are small practices with 15 or fewer clinicians. They will have double the points that the others will receive. Also, if you're participating in an alternative payment model, practicing in a certified or patient-recognized patient-centered medical home, non-patient facing, or practicing in a rural area or health professional shortage area, or HPSA. Now, you'll notice a couple asterisks here. For non-patient facing, or if you are practicing in a rural area or HPSA, you must have greater than 75% of your NPI billing under that Group 10 during the determination period. So how do you choose improvement activities? This is a question Sandy and I got a lot last year because it was new. And so first off, we would recommend that you review the 2018 Improvement Activities Inventory List. And this is a link that will be available that is also under the resources page on the CMS website. You'll see at the end of our presentation as well. So we highly recommend you review this list carefully. As I said, we're going to touch on some of these key highlights, but by no means is this all-inclusive. So the activities can be from any of these 9 subcategories you see here. There are no requirements for the subcategory or number per subcategory that you choose. It's completely up to you. How do I submit improvement activities? The same methods that were available for the 2017 transition year, Year 1, are available for this year, and those are listed here. Attestation on the data submission system was probably the one I saw the most and was helping, I was able to help practices use the most, but also you have a Qualified Clinical Data Registry, Qualified Registry, Electronic Health Record, and the CMS Web Interface if you are in a group or virtual group of 25 or more. Please note that CMS is not going to combine improvement activities if you report using more than one of those submission methods, however. An important piece of this improvement activities is that you keep your documentation to support and substantiate the improvement activities you chose. So there is a document that is on the CMS QPP Resource Center. It's under the 2017 resources. It's named MIPS Data Validation Criteria. And there on that list, you find a list of the activities with the suggested documentation for each activity. Now that is under 2017, and they will have a new mixed data validation criteria for 2018 as well. And it's not out there yet under 2018 resources, but CMS is continually updating those resources, and they will have that out there. But for now, if you want to use that 2017 mixed data validation criteria, that will give you a start if you are looking at those that were available for 2017. So there are many different groupings that you can see as when you really look through all these activities, and I just have a few here for some examples, but I just wanted to list some of these to give you an idea of that there are common themes that all the way throughout these 113 activities. To save space, I haven't listed the name of the activity by its ID, but those are listed on the QPP.cms.gov website. So this just gives you an idea of some possibilities. For instance, there are 5 different possible improvement activities if you have a process in place for staff education and assessment. Or those that remind patients of missed or overdue appointments, that's an activity. If you have a process in place to identify and care for those patients after they've been in the hospital or had an ED visit, there's a couple there. And also, if you have established a process to prepare for next day visits. So, again, we could go through a ton of groupings, but I just wanted to give you an idea that many of these don't require an electronic health record, as I stated earlier. And so it really would be in your best interest to look at that entire list using that link and go through there and choose some of those activities that might be a focus for you that you would like to improve on in your practice. Now, there are about 20 new activities this year, and so I just have a handful listed on these next couple slides that I thought might be a good place to start looking. And again, this is just a sample. Of course, you want to review those that might be of more interest. And CMS's goal is that you find activities that work for your practice and what's important to you. Now, there are new activities for every subcategory of those 9 subcategories except for the emergency response and preparedness subcategory. So you will see at the bottom there is an asterisk by the final one, promoting the use of patient-reported outcome tools. I've added this asterisk on both slides as a way to show you that these are also eligible for the promoting interoperability bonus for using search for the improvement activities. And Sandy will talk more about this soon, but I picked out some that might be of interest to you that you could start with first. But with opioids being a big focus, you can see they have something there for the CDC guidelines and training on that, as well as antibiotic stewardship, alcohol use, patient navigator programs, providing educational opportunities for new clinicians as well. Now, there are many more medium-weighted activities for year 2. Again, just a sampling here. You may notice that we have more of these improvement activities that are eligible for that promoting interoperability bonus. And so here are some that I thought might be something you may already be doing. Again, just to draw your attention that they really tried to listen to input from everybody on adding more activities. And so I'm really happy with some of these that they have. And hopefully, maybe you may see some of this there. And I also added the pages of the final rule for the year 2 where the listing of the improvement activities begins. It goes through those. So if you are so inclined and want to do that, by all means, you may do so. But please don't forget to consult your SURS organization and QIO organization. We're here to help you. Now, there are other changes to improvement activities that I thought might be good to maybe highlight just to draw your attention to this. Not only did CMS add new activities, but they also made some changes. So, for instance, some activities were given a higher weight, moving from medium to high weight. And those are leveraging the QCDR to promote the use of patient-reported outcome tools. This one actually changed their title to promote use of patient-reported outcome tools, but I wanted to show the former title, so in case you used that last year, you would know that this has been moved up to a high weight category. And the other is engaging patients and families to guide improvement in the system of care. There was an improvement activity that went from a high-weighted activity to a medium-weighted activity, and that is the TCPI participation. They removed an activity of participating in CMMI models such as Million Hearts campaign. They also changed the promoting interoperability bonus for a couple. So instead of having there be no bonus, they decided after hearing input from many stakeholders that they would give a PI bonus for some of these activities. And so I have again, leveraging QCDR to promote the use of patient-reported outcome tools and engaging patients and families to guide in improvement of care. Then, one other thing to note is the bonus for the PI went from yes to no, so you will no longer get a promoting interoperability bonus for improving practices that disseminate appropriate self-management materials. Now, other changes seem to be mainly providing more description, for examples in support of the activity or the actual title of the activity. So again, please consult the website and the resource materials used in the link at the end of the presentation to verify there were no other changes to the activities you are considering doing for this year. When you talk with your team about the 2018 MIPS plan, we wanted to provide a few tips on continuing that conversation. I have some here. First of all, look at that spreadsheet or that document, the MIPS data validation criteria for suggested documentation for those activities that you select. Keep that documentation for at least 6 years. Then another piece that people didn't seem to be able to use some of the activities because they had not obtained the baseline data and steps taken to improve the data. So maybe they were taking steps, but they never took the original baseline. So we encourage you to make sure that you obtain that baseline data if your improvement activity uses that type of information. And also consider your patient population and the clinical conditions you treat. There are a few listed here, but there are many improvement activities around different types of conditions. So maybe you want to look at those first. Also, do you have an electronic health record? And if so, do you use the advanced functionality of the electronic health record? For instance, patient education, decision support, and patient portal. Do you participate in a qualified clinical data registry? It seemed like we had more of those last year. I was very happy to hear that. So there are some activities for those. And overall, just consider your current workflow, your activities, and your practice goals. Of course, again, as I can't say it enough, consult your SURS and QIO contacts to help you with any questions. Now I'm going to turn it over to Sandy to talk about the Promoting Interoperability Performance category.
Thanks, Michelle. Another resource, I want to take with improvement activity for just a minute. Another resource I used a lot, and I don't think they have it out there yet for 2018, but under the 2017, if you go in and look at your scope of practice, like radiologists and ER physicians, sometimes the list of improvement activities is overwhelming. If you go in and pull up the guide for those particular scopes of practice, it'll give you suggestions of improvement activities, and it'll also give you suggestions of quality measures. I use those a lot, and I know they're updating those for 2018 to include some of those improvement activities. Those should be out there real soon, too. All right, thanks, Michelle.
Thank you.
And moving on to the Promoting Interoperability, or PI, a.k.a. Advancing Care Information, or ACI, more acronyms. Anyway, this category, really, the Promoting Interoperability Performance category really promotes or evaluates your organization and your MIPS-eligible clinicians' patient engagement and electronic exchange of health information using the certified EHR, kind of the level that the usage that you're using, and that's the purpose of this category. Okay, I'll get to the right slide here. So, to continue their commitment to promoting and prioritizing interoperability of healthcare data, CMS is overhauling and streamlining the EHR Infinity program. Michelle talked a little bit at the beginning. And this is for hospitals and Medicaid eligible clinicians, also CAUSE. as well as the Advancing Care Information Performance category for the QPP program. Now, this change will alter the existing requirements of the meaningful use to a new phase of the EHR measurement with an increased focus on interoperability and improving access to patients' data, but it does not, this rebranding does not merge these two programs or combine them, because we're getting some questions on that. And there's still two separate programs, the Meaningful Use EHR Incentive Program for eligible clinicians, eligible professionals for Medicaid, critical access hospitals, and just regular hospitals. And now all of this stemmed from this renaming and overhauling. All this stemmed from the IPPS rule that was rolled out in late April. And CMS really wants you to know that they're listening and they're trying to reduce some burden. They're reducing some of the measures. They're just eliminating some of the measures. And then they're looking at some of the different programs that hospitals have to report on and trying to get so you're reporting that one measure and it'll go for all the different programs. So they really are listening, trying to reduce burden, but however still have successful efforts to be able to make sure that we're providing the quality and the value that we need to be. But anyway, it's really interesting to see how this plays out as we work through the promoting interoperability. Okay. So the category, for the PI, participation options, the category weight stays the same at 25% for MIPS eligible clinicians and 30% for those working that are using the special scoring under the MIPS APM. The use of the 2014 or 2015 CEHRT is required to participate. Similar to 2017, participation can be done at the individual or group level. And they've added one additional participation level, and that's the virtual group. Now, a virtual group can be made up of solo practitioners and groups of 10 or fewer eligible clinicians who come together virtually. So it doesn't matter where they're located or what their specialty is. They just come together virtually to participate in MIPS, and that's for a performance year. Now, for 2018, you had to apply for this before December 31st, 2017 and get approved. So if you're not in a virtual group now and you're thinking you might want to be for 2019, now is the time to start doing your homework and getting that application going. The same as last year, the level of participation has to be the same across all of the performance categories: quality, PI, improvement, activity, and cost. If you're going to participate as a group, all of those categories you'll participate in as a group or as an individual. I don't really see any significant changes in the reporting for the PI category. We have the option of the two major sets. These were inherited from the modified Stage 2 meaningful use and the Stage 3 meaningful use, and they're in order to gauge the level and the maturity of the EHR usage. So we have what are now called the 2018 PI transition option objectives and measures, and those are for folks using the 2014 version, 2015 version, or a combination. And then we have just the regular PI objective and measures, and those are for folks using in 2015 or a combination of 2014 and 2015. There's the major specification sheets for 2018 are out there on the website, on the QPP website now, so you can look up each one of those. The minimum performance period is 90 consecutive days up to 1 full calendar year, and submission methods remain the same: attestation, EHR, QCDR, qualified registry, and the CMS web interface, which is for groups of 25 plus. There are two bonus opportunities that you may want to take advantage of. There's a 10% bonus for the exclusive use of the 2015 edition CEHRT. So that one you would have to use PI objectives and measures. And then there's a 10% bonus for using the one improvement activity. And Michelle talked a lot about that. So those are great ways to get some extra points. Now, the reweighting of this category caused a lot of confusion for us here and probably for some of you guys. But I think we got it all figured out by the end of last year. And eligible clinician must meet certain criteria in order to qualify for reweighting to 0 for that category. So not having a certified product is not sufficient by itself to qualify for reweighting. The reweighting to 0% means that the PI performance category is not included in the MIPS final score at all, and it gets reallocated to the quality category. Now, there are two types for reweighting. There's the automatic and there's the applied for. The types of MIPS eligible clinicians listed on the table on the left qualify for automatic reweighting. So if you're practicing in an ambulatory surgical center, if you're hospital-based, you're a physician assistant, nurse practitioner, clinical nurse specialist, certified registered nurse anesthetist, or clinicians who lack face-to-face encounters, then you would qualify for automatic reweighting. Now, you also have the option to report, and if they do submit data, it will be scored and weighted under that PI category. Now, if you're confused as to whether or not your eligible clinicians qualify for one of these, you can actually look at this on the QPP website. When you look up the MPI tool, it will tell you if they're hospital-based, if they're non-patient facing, or if you want to visit with one of us in the support contractors or the QIO or the SUR for your particular state, you can reach out to us, and we have a participation list that we can help you to find that out too. So please feel free to do that. To qualify for the hospital-based, I think Michelle talked a little bit about this with improvement activity. It has to furnish over 75% Medicare charges, and that's in places service 19, 21, 22, and 23, or 23, and those are inpatient, on-campus outpatient hospitals, off-campus outpatient hospitals, or the emergency room. And that hospital-based determination period runs from September 1st through August 31st, 2 years prior to the performance period. Now, if you're reporting as a group or a virtual group, all MIPS eligible clinicians in the group must qualify for reweighting in order for the PI score to be reweighted to 0. So before the whole category score can be reweighted to 0, all of the clinicians, MIPS clinicians in that group must qualify. Otherwise, you just don't have to submit for that particular MIPS eligible clinician that meets the automatic reweighting. So in the second box there, or table on the right, you may apply for reweighting. So this is the second type, and this is the applied for. And using one of these reasons, you can apply for this. In this small practice, this is new in 2018. If you are in a small practice, which means 15 or under, and you have a valid reason, just the size is not a sufficient reason to apply. But if you do have a valid reason, you can apply for that. Now, applying for this is only good for 1 year, so you would have to reapply each year. If you're using a decertified EHR technology, if you have insufficient internet connectivity, if there's some extreme and uncontrollable circumstances that's happened with your eligible clinician or your organization, so you have no control over whether the CHRT is available. So you must submit your application by 12/31/18 for CMS. It's on the website. It will be on the website soon under the MIPS tab. You'll go into the ACI or the TI category. And that's what it was last year. I'm assuming they'll put it in that same place this year. They're really focusing on trying to get everything changed to promoting interoperability, and then they'll be adding this application. And again, it has to be submitted by December 31st. So let's talk about scoring. It's very similar to last year. A clinician earns promoting improvement measure points as a sum of 3 components. There's the base, the performance, and the bonus components. There's no change to the base score. It's all or nothing measures. You have to report all the measures and pass to receive the 50 measure points before you can move on. Then you can report any other performance score, the performance measures, and you can score and earn up to 90 measure points. And then you have an opportunity to receive up to 25 measure points, bonus points, depending on which options that you select. So there's a potential, if you add those all together, there's a potential to earn up to 165 major points. But any score above 100 will be capped at 100. And that will give you full credit for that for the PI category. Now, this scoring was designed with some flexibility, so everyone has to report on the base measures. And these are ones that CMS really feels directly align with their goals of security and interoperability. And then the performance and the bonus categories are designed to focus on measures that are most relevant to you and your practice. CMS will calculate a percentage point score for each category, each of these components, and then they'll add these together and then multiply it by the category weight of either 25% or 30%, depending on what track or path of your participation. So let's talk about each of these little components for just a minute. The base score, you need to meet all the requirements of the base measures in order to receive the 50 points. So you'll have to submit a yes for the security risk assessment measure, and at least one in the numerator for the numerator-denominator of the remaining 3 or 4 base measures, depending on which options that you select. So all measures must be met for this measure set. Otherwise, the entire PI category is assigned to 0. So this slide just shows you the 5 base measure requirements for the PI set, and then the 4 for the transition set. The asterisk refers to there are several measures that have exclusions that you can use. And we'll go to the next slide here and see these exclusions. So e-prescribing was in both measures, option sets. And so any NIST eligible clinician who writes fewer than 100 permissible prescriptions during the performance period can exclude. The HIE exclusion, which is in the transition measure set only, is for any NIST eligible clinician who transfers a patient to another setting or refers a patient fewer than 100 times during a performance period. The send a summary of care exclusion is in the PI measures only. And this one is any NIST eligible clinician who transfers a patient to another setting or refers a patient fewer than 100 times during the performance period. And remember, your performance period could be 90 days up to a full year. So you might want to juggle with some of these if you feel like that is more applicable to earning more points for you. And then the last exclusion that you can use is request and accept a summary of care exclusion. Again, that's only in the PI option set. And that's any NIST eligible clinician who receives transitions of care or referrals fewer than 100 times during the performance period, or has patient encounters where the NIST eligible clinician hasn't ever encountered the patient fewer than 100 times during the performance period. Moving on to the performance score, this is calculated using the numerator and denominator that you submit, and then for the public health measure, the yes or no response. Obviously, the higher the numerator, the higher points you're going to get, and there's a potential for a score of 90 percentage points. And notice that the measures with the asterisks are included in both the base and the performance scoring. So it allows for clinicians to earn a score that contributes to performance, too, in some of those base measures. Each measure is worth up to either 10 or 10 to 20 measure points. So most of them are up to 10 measure points, except for in the transition set, there are 2 measures that are worth 20 points. And those are provide patient access and the HIE or summary of care. Now, the only performance score that is yes or no is the public health reporting measure. And if you submit yes, you'll receive a full 10 percentage points for that one. So the performance rates are scored on a static decile scoring scale. So it's not pure benchmark like in quality category. So, for instance, performance rate of 50% or 51% or 53% or 41-50% gives you earns a 5 points out of a 10. If you have a performance rate of 60%, it's going to earn you 6 points out of 10. If you have a performance rate of 61%, it's going to earn you 7 points out of 10. and so on. So how is the bonus score calculated? Well, this is your opportunity to improve your score. If you feel like you didn't just do so well on the performance score, this is an opportunity to improve your score because you can get up to 15 or 20 total bonus points can be earned depending on which majors that you choose. Reporting a yes to one or more additional public health and or clinical data registries beyond the registry reporting in the performance category will result in an additional 5 percentage points. Reporting yes to the completion of at least one specified improvement activity using your CEHRT will result in 10 percentage bonus points. So that's why Michelle really highlighted that, because that's 10 additional points. And when you're reporting as a group, the group can submit a yes for one of these majors as long as one clinician in the group is actively working with one of these entities. So not everybody has to be doing that immunization registry or that cardiac registry or that one particular improvement activity as long as one clinician is if you're reporting as a group. So again, there's a total possible percentage points of 165. You can only score, if you score over 100, it's capped at 100 and you get full credit. This list is just a comprehensive list of the improvement activities that are eligible for the PI category. And Michelle talked about that. So we'll move on here. So let's just do a quick hypothetical scenario. This eligible clinician reported on all the base majors and they received 50 percentage points for that because they passed it. So they automatically got the 50 bonus or major points. And for the performance category, he received 40 percentage points out of a possible 90. And then they did not submit any bonus category points. So you add those add together the three components there, 50 plus 40 plus 0, and you get 90 percentage points. And then you multiply that by the 25% percentage weight, or 30 if you're in the ATM scoring category. This one I used for the example was 25%, and the final score for the PI category is 22.5 percentage points. I would take just a few minutes to go over a few of the FAQs that we received in 2017 for this category. What is the minimum needed to report for PI? Well, you have to use a certified EHR technology. You have to submit the performance period of a minimum of 90 consecutive days. You have to attest to the good faith statements that CMS will have you submit yes to on the prevention of information blocking attestation, and that you will be willing to work with ONC for a direct review attestation, all in good faith if needed. You must submit yes for the security risk analysis measure. And then you have to meet all the other base measures by submitting at least a one in the numerator for the remaining base measures, or an exclusion if that's applicable. So again, that's how you can meet the minimum. Can I avoid a payment adjustment by reporting on IA or PI only? Yes, you sure can. For 2018, the threshold is 15 points. And these are a couple of examples. Say that's what you want to do again this year. You want to just meet the minimum. You just want to avoid that payment adjustment. You don't want to worry about the quality measures. Of course, we're not encouraging that. But at some point, sometimes that's where you're at in your organization in the situation. So you could just report on improvement activities only. 2 high-weighted activities would give you a full 40 points for that category, and so that would give you 15 points, which is the threshold. 1 high-weighted and 2 medium activities would again give you 40 points. 1 high-weighted, and if you happen to be in a small, rural, or HIPSA qualifications, with those qualifications, it automatically doubles your score, so that would give you the 40 points. Or you could do the base ACI score, and 50% of the, half of the, or if you get 50 percentage points for the base score, and at a 25 percentage weight. That's going to give you 12.5 points for ACI or PI, and then one medium medium weighted improvement activity. That's going to give you 3.7, so that will be a total of 16.2 for your final score. So again, you'd be above the threshold. So yes, you can avoid the payment adjustment by just reporting on IA only or IA and the PI base score. What if my EHR doesn't have the capabilities I need to be successful? Well, CMS recognizes that EHR vendor issues can be a barrier to achieving your QPP goals, and they really encourage clinicians to create awareness by reporting these issues and they have a formal process in place. So if you have unresolved complaints about your EHR vendor and you feel the Office of National Coordinator for Health IT needs to be aware of a situation, the following action items are available. First of all, start by contacting the product developer or vendor. If the developer or vendor is unable to resolve the issues and you think the issues relate to the product certified capabilities, then you should contact the appropriate ONC authorized certifying body, which should be able to work with you and the developer to resolve these issues. And you can go out into the Chapel website to find out who certified that particular product. These were the 3 certifying bodies, and I've provided their website and then an email to reach out to them. So if you work with them and you contacted the developer as well as the ONC authorized certification body and you still have outstanding issues, then there is a online form that you can submit your issues via this ONC's complaint forms, and I've provided the link for you on this presentation. And you just go out and complete that form, let them know what your issues are, who your vendor is, et cetera, and they will be looking into that. And they really are stressing for us to let you know that that is available for you. All right, so before closing for questions, let's just continue the conversation about some tips for promoting interoperability. Number 1, begin your security risk analysis now. If this is your first time reporting the PI or the ACI category and you've not done a security risk analysis, there's a free online tool. It's the ONC tool. There's instructional videos, and I've given you the website link for that. Use IT staff to help begin completion of this analysis. Engage all your clinicians and staff to encourage patients to use the portal. The portal, you can really increase your performance rate by using the patient portal. There's so many measures that are around that, such as providing patient access, the DBT, secure messaging, patient education, the patient-generated health data. Again, try to get the bonus point for using the IA, the improvement activities, certified activities. And then, if you're not already doing this, try to collect all the direct addresses of those practices who you refer patients to, or they refer patients back to you. Then you can get your summary of care measure up, performance rate up, and additional points, and improve your percentage points for the performance category. So those are just a few tips. I'm sure you guys have some other tips, some things that you've been doing really well to improve your scores. And so I think, Michelle, are we ready to open it up for questions or comments, suggestions you might have for folks?
The leader has unmuted your line.
I've opened up the line, so please feel free to ask your question. Or maybe we could ask, did anybody have any problems or didn't score as well as they had hoped for either one of these categories? And maybe they would like some suggestions from either Sandy and I or somebody else on the call. This is an information sharing. We'd love to have that.
I've got a quiet group. I think both of these categories are pretty similar to what they were last year, so they shouldn't cause too much confusion for you folks that participate in those categories. We are watching closely for the notice of the proposed rulemaking. For year 3, we expect that to come out sometime in early summer. Hopefully, our hope is to have that out sometime in May. I'm not sure. I think it's looking more like June, but they surprise us. We'll plan a webinar as soon as that's available, just to give you what some of the recommendations are and some of the changes may be. At that point, then you'll have an opportunity to make comments to CMS before the final version is out, and usually in November. So stay tuned for that. We've got some resources here on the resource page. Again, CMS has done a great job on the QPP resource page on their website. So here are the resources that you may want to use for these 2 particular categories. And they just recently put out the new group participation in MIPS 2018 resource too. If you are doing group participation, take a quick peek at that.
Before we close, anybody think of a question you may have?
This is Jody Gunn, and I do have a question. I would like to know if you have any examples of what patient-reported outcome tools might include.
Oh, yeah. Let me see if I tried to kind of look at each of these a little bit, and let's see here. I think I need to get on my classes here. It's interesting. I thought I had something on that, Jody. I tried to take little notes on that, but I don't see it here. I'll keep looking here in just a second, and Jody, I'll send you that if I don't see it, because I did. Oh, here we go. I think this might be what we're looking for. Okay, SC Pro, but maybe not. I'm not going to, that wasn't it. That was for engaging patients and families to guide the system of care. So I apologize, but I will send that to you, Jody. I have your name here, so I'll send that to you. And then also that they did a really good job of expanding out maybe some of the explanations of these improvement activities with more examples for that. So please take a look using that link, and then I will send that to you.
Okay, I appreciate that. Seems like there's a lot of emphasis on that, so it would be wise.
Yes.
And I guess the other question I would have, too, is just a little clarification about what happens as you move forward with MIPS if you become part of an ACO. An ACO. And do you report for MIPS? How does that work?
Sure. So it depends on what ACO you would participate, and not necessarily what ACO, but what track they are in. If they're for the Medicare Shared Savings Program, and the ACO has to be a Medicare Shared Savings Program for your MIPS to change. So if it's not a Medicare Shared Savings Program ACO, then your participation in QPP MIPS remains the same. But if it's a Medicare Shared Savings Program and it's a Track 1, then you would be applicable for the special scoring, which is the quality is 50%. And that's for 2018. We'll just speak for 2018, and this is the same as what it was for 2017. 20% for improvement activity and 30% for the PI or the ACI. So the quality measures for folks that are participating in an advanced APM are part of their standard participation in the advanced APM. So they have to report, just for that participation, they have to report quality measures. and those quality measures are reported through the CMS web interface. And most of the ACOs are doing those on behalf of their practices, their TINs, their organizations. And then they have to report like 33, 34 different quality measures. Of those, 15 of those are the same ones that would be reported for a MIPS-eligible clinician through the CMS web interface. So CMS will automatically just pull those over for scoring for that category for MIPS. By participation in the ACO or the Advanced APM, you would automatically get full credit for the improvement activities, because that gives you full credit for that. And so then the ACI or the PI, the Promoting Interoperability category, is the one most ACOs are requesting that their TIN organization, by TIN, you go in and as a group, because it will be group level reporting for you. You submit the ACI yourself, or some of them are allowing you to provide that information to them and they'll go in and submit the ACI. But most of them want you to go ahead and submit the group level ACI data, just like the MIPS, just like you would if you were just MIPS eligible clinician. The cost category is not weighted for your final score for MIPS for the Track 1 ACI, because they feel like CMS feels like you're already being evaluated for cost for your participation in the Medicare Savings Program 1, the Advanced APM or the APM. So cost is not taken into consideration for the score. Does that help, Jody? Does that give you?
Yeah, I guess the biggest thing I was just wondering how it really changes for us in terms of submission if we do join, like you said, a shared, I would assume it would be a shared savings program. So there's still some responsibility of the organization, but a lot of that responsibility, it kind of is assumed then by the ACO.
Yeah, I think it's their responsibility. I'd call it support, because you're still going to have to help your ACO get your quality measures out of your EHR. I mean, no, they're still going to be looking for your assistance with that. It just isn't. They're going to go ahead and submit it for you through the CMS web interface tool. But yeah, the folks that I'm working with I think are feeling like they're getting very good support from their ACOs to help them with this.
Mm-hmm. Okay, well, thank you very much.
You're welcome. Thanks for your questions, and we'll get back to you with a tool.
Sorry about that, Joyce. With examples of that, I don't want to misstate anything. I have some ideas what it said, but I just don't want to misstate.
Oh, that's absolutely fine. Of course, I asked the question that you didn't have it right.
No, hey, Jody, now that's not always the case. There's a lot of them out there.
When it comes to improvement activities, I always have to go back to that validation criteria and look and see what are they suggesting. And they're so vague on so many of them, because it is a little bit of using your own judgment on a lot of them.
Yes.
I don't think that they, as long as it looks like a process that's going to, show improvement and patient engaged, type things, and promoting better processes and quality, then I think that they're very, very lenient and very vague about what specific tools you have to use, or what specific workflow or process you have to have in place, because it's so unique to each individual organization. Great question.
Well, thank you very much.
Thank you.
All right. Well, if we have no other questions, we will let you get to lunch, maybe. All right.
Thank you so much. Bye-bye.